Hi, today we'll be talking about groin pain, and I'm going to use groin pain to showcase a review of clinical reasoning. Now, I know you've done this before, but the subject is so important that it bears repetition and more repetition. Also, you're familiar with the terms and the concepts now, so this will give you increased confidence that you do know what you're talking about here, and also sharpen up some of the ways you think about this. Be absolutely clear about the pain we're talking about. This is almost a point pain in the groin. Now, it may refer out from the area, it may radiate a bit, but this isn't the dull, achy pain that covers the entire groinal area when the lumbar spine is referring to, particularly L1. Groin pain in general can be L1, T12, even T11 can be considered sort of in the groin area. But this is an almost point-specific pain that gets worse by spreading a bit. So as long as we understand that, we're good to go. Always generating a hypothesis, you have to consider what's actually under the pain. The structures are under the pain that can give you this. Now, if you look at the anterior picture there, you've got all sorts of structures, including the pupil rama. We're not looking at fractures here, all right? This is generally much more mundane. So what's showing here is I for the inguinal ligament. It's not the inguinal ligament is particularly painful often. It's that stuff ruptures through it. So there's inguinal and femoral hernias in that area through the inguinal ligament. The SI joint can certainly refer here, particularly if the anterior capsule is damaged. And this will refer right into the groin area. The big one, of course, is the hip joint, which you can see in profile there. The psoas bursa and psoas tendons, B and P respectively, are not big common causes of hip pain, maybe in certain types of athlete, but in general practice, it's not a major cause of groin pain. And you can see the bursa and the psoas tendons from the side as well. So all of that should be considered when you're making a hypothesis. You should be able to visualize these structures. So selecting a hypothesis, you've got a number of different ways you can do it. If you're looking at a hypothesis, severe and urgent pathology, such as a high cervical fracture, that's your hypothesis, and you actually need to disprove it to move on. This isn't a matter of proving this hypothesis. Assume that it is present and disprove it. Actively try to disprove it. If you can't disprove it, get it out. This is dangerous and it wants to go. Or we've got other choices. So we can look at the most likely hypothesis, least likely hypothesis, easiest to treat, and then we're left with exclusionary diagnosis, which is where you can't figure out what the hell is going on, and what you're left with there is getting a second opinion. And if you can't get a second opinion because they can't figure it out neither, it goes out. It almost certainly isn't a standard orthopedic neurological condition, simply because you don't know it. So it goes out, and you're probably going to need further imaging, or an arrogant physician who says, oh, don't worry, go back to another therapist. But you don't want to get caught up in that. If you don't know what it is, say so. Now, looking at the most likely hypothesis, this is the one we all tend to go for, because you're pretty sure that's what it is. The problem with it is loaded with bias, confirmation bias, anchoring, premature conclusion, and so on. This is actually weighed down with biases and errors. The least likely is probably the correct way of doing this. You disprove different, you go through pretty much every hypothesis you can think of before you get to that one, which means that there's no premature closure on this one. You're also not anchoring because you've gone through so many, and there's no confirmation bias in there because you really don't think it is this one, unless you actually that confirmation bias is when you say it's not there, or it is that one. But it's the one that's least likely to give you bias. The problem with it is it's not one that you want to do. It takes forever to do this. It's as frustrating as hell, and it's not one that generally people do. I certainly don't, but it's probably the best way to do it. The easiest to test is a very quick way of doing this, very quick. It's not even the most likely. as long as you've got a good screening test, you can dispose of these quickly. Something like tennis elbow, for example, the testing for tennis elbow is very, very rapid. So it's an easy enough one to disprove if those tests are negative. It's not the worst way of going by any means. Over the hip, we have the following hypotheses. Hip arthropathy or dysfunction, which is probably the most common one of the lot. Stress fracture, not rare by any means. Iliopsoas tendinopathy and psoas bursitis, neither of which in my practice has been ever been common. Sacroiliac arthropathy and sacroiliac joint dysfunctions, which is not rare here, but it is uncommon. For the ventral ligament to actually produce pain here, it's unusual. The ventral ligament is the weakest ligament around the SI joint. It's the one that's most likely to get torn with trauma, but even so, this is an uncommon event. Viscerogenic, that's not in the pictures, that's not in the diagram of the anatomy, but it is a very real possibility. So most viscerogenic pain is going to give you that heavy, dull, deep, diffuse pain that comes in waves. This is much more common in women in the pelvic area than in men because they've got more going on there. So if you're getting that type of pain, just fire it out. But the visceral linings won't give you that pain. It'll give you musculoskeletal pain. Inguinal and femoral hernias, generally speaking, it's a very sudden onset of really quite severe pain when they're lifting, bending over, doing some really strong exertion. And generally speaking, they know what's happening. They'll go to physicians. You don't see many of them. I've seen a few because they haven't come on that way. They've come on much more gradually and insidiously, and they've not known about it until they're starting to get some pain there. And the pain initially wasn't that terrible anyway. So these can creep in there. And then referral from the lumbar spine. As always, screening tests can play a really big role in ruling things out. High sensitivity allows you to rule stuff out. At least provisionally, you can move on to the more likely positives. So let's have a look at some of these. Hip quadrants, I think, is really a good test here. It's not specific, though. The quadrant will give you hip joint pain. If you have a tendinitis there, it's probably going to be positive when you squeeze that. So it could be an arthropathy, such as an arthrosis, arthritis. It could be a labral tear. It can be the biomechanical dysfunction, such as the UFA or the lateral rotation subluxation. There's an awful thing, a lot of things this can be. Stinchfield's test actually does have validity numbers associated with it, but they're not terribly good. If you don't know it, Stinchfield's test is you get the patient to do a 10 or 15 degree straight leg raise, hold it there, you then push the leg down. If pain is generated, it's felt in the lumbar spine, it's a lumbar problem. If it's felt in the groin, it's a hip problem. And if it's felt in the SI joint, then it's in the 14s area, then it's an SI joint problem. The issue with this is sometimes the hip will refer pain into the buttock, and this is not allowed for. The sensitivity and specificity is not very good on this test at all. So because of low sensitivity, it's a rotten screening test. Squatting is definitely, almost certainly, going to give you pain in the hip when you do this. And again, it's not going to be specific. Faber's test as an established sensitivity rate of around about 70%, I think it is. The specificity is not great neither because it does test other things. Fordin's test is very sensitive for the SI joint. It's probably reasonably specific for it as well. This is the subjective test, but of course that's no use when we're looking at groin pain because the subjective Fordin's is going to be negative because when you ask them where the worst pain is, they're going to point to the groin. But objective Fordin's may very well be positive when you're doing this stuff and the SI joint is producing that pain. And then finally, palpation into the groin. If you're palpating deeply enough and it's negative, I think you can rule out tendinopathies, bursitis, and so on. So again, it's a fairly good screen test, providing you go down deeply enough. So this is very much dependent on the size of the patient, how much of your arm do you have to get in there, and on the ruthlessness of the therapist. So let's have a look at the process here. I'll put glasses on because the print's getting a bit too small for me to see. And I do this once and it's always different when I do these flowcharts, so I can never remember them. So here we go, groin pain. If the pain is viscerogenic, fire it out. If it's somatic, Look for a history of severe exertion. If you have a gradual onset of pain with severe exercise, stupid amounts of running, if the answer is yes, there's a really good chance it's a stress fracture. My suggestion is you get it back to the physician for imaging. If it's been imaged and there's no stress fracture, I don't mean an X-ray, I mean proper imaging for a stress fracture, then we're going to move up and see what's happening with a sudden onset pain. So, because this could be a very slow hernia. You could do the inner flexion quadrant just to reproduce that pain if you really want to, but understand that you may be stressing a fracture. If it's a sudden onset, it's less likely to be a stress fracture, but it can be a stress fracture. Sometimes they just wear out, and then suddenly, boom, it goes, and now it's painful. But this can also be something like an inguinal hernia, particularly if the exertion is a single one-off lift or something else that's exertion rather than over-exercise. So now you've got to observe to see if there's a lump there or feel for a lump when they cough. If the answer is yes, send it out. But a word on testing, when you're looking for a lump or you're looking to palpate the bulge when they cough, do it in standing because both tests are much more sensitive. The weight of the viscera pushing down will bulge more out than if they're laying on their back. We're going to look at another chart which carries on from this point next. Okay, so if you remember, we stopped with a hernia and with severe pain on exertion. So let's go back, continue along the sudden onset of pain after severe exertion. All of this is in blue, just to keep it simple for you, because it's a fairly complex flowchart. If the answer is yes, we said it, this can be a hernia, and we say, no, it's not, okay? Everything is saying that it's not. Then you can start thinking about this being a lumbar referred pain. So this would be L1, but go up and do PAs. Make sure you cover the entire lumbar spine, but particularly the upper lumbar, lower thoracic spine. Do PAs up there and see if any of these are painful locally. Now, that doesn't mean to say the referred pain is, but if the groin pain is present and you've got sensitivity over the lumbar spine, it may well be that it's referred from the back. If there is no tenderness there, then it's fair to say that it's not the lumbar spine. That's probably the big thing here. There is no tenderness, then we can move on and think about this being a tendinopathy or a bursitis. Pick one, test it. So if you're thinking this is a tendinopathy, do your contractile tests. If they're positive, then it's a tendinopathy. If they're negative, the standard contractile test, but it's positive when you do the test in full extension of the hip, pushing on the flexion, so the psoas tendon pushes down on the bursa, then it's probably a bursitis. This is assuming that palpation was positive. If palpation was negative, then it's probably visceral. Coming down, we've got to, there's no pain, no history of severe exertion or exercise. We can go in and do a screening test, which I would suggest is a quadrant test, the inner flexion scour, if you like. Now, if that's positive, we can start thinking H1 might well be an arthropathy. Look for a restricted range of motion and pain. If the answer is yes, then do the passive accessory movement. If the passive accessory movement is positive, then you have an hip arthropathy. You're doing distractions, so it's a hard capsular infill. If it's not, then you may be looking at a biomechanical dysfunction here or a labral tear. Look for the other signs of these, that is medial rotation loss, extension loss, Fabers, and what's the other word? The other word. Inner flexion scout, which we've got, then manipulate it and see what happens. If it gets better, then it could have been any of those things: the labral tear, UFA, lateral rotation, subluxation. There's no real way of telling which of these three things it is. If that was negative, it may well be a labral tear that is simply not responding to your manipulation. Aim it out for imaging to see if it is a labral tear. If the range of if the hip ranges are all full and there's no pain, then again you might be looking at a bursa or a tendinosis or a tendinopathy, probably a tendinosis. If the quadrants are painful, then it could be a tendinitis. But if it's tendinosis, the quadrants may well be negative. So if they are, then palpate for the bursa and the tendon. If palpation is negative, it's probably visceral. If they're positive, do the same thing you did before, contractile testing. And if they're negative, then it's probably a bursa. Even if the extended hip resisted flexion test is negative, it probably is still bursa. So understand what this represents. It represents one way of processing the information. This isn't necessarily the way you need to do it. You can do it anyway, but you need to understand the process that you are using. All right, this is one system of processing that I understand. It may not even be the one that I use on a particular patient, but it is one way of looking at this in an overall view. Remember, you're not going to do all these tests. You're going to pick your hypothesis, and then you're going to test it, and it may come out to be a positive one immediately. So this is an overview of processing. Okay, so let's have a look at some of the pathologies there that can show up and how they're likely to show up. So first of all, stress fracture. Inner flexion quadrant is going to be positive, but before that, you should already know that they have a history of severe exertion, severe exercise, and if they're a female, postmenopausal or malnourished, or just simply over-exercising, then it's more likely to be a stress fracture than it is in a man. However, remember that stress fractures connect as outliers and they don't look like this at all, and you can have a sudden onset of pain while they're exercising. Probably the best thing there, with that type of thing, it may well be an inguinal hernia. I would go from that hypothesis of stress fracture to a benign inguinal hernia, look for the bulging. If it's not present, go back to the stress fracture. Either way, they're going to go out from you. Arthropathy or biomechanical dysfunction of the hip. Inner flexion quadrant is going to be positive. You're going to find evidence of this objectively, whether it's Fabers or whether it's UFA, lateral rotation subluxation, or a labral tear. You're going to find all those things we talked about: lack of extension, lack of medial rotation, positive or negative arthrokinematics, and positive Fabers. If this is actually arthrosis or arthritis, arthritis is going to show up with a lot of pain. It's going to be much simpler for you. But if it's an arthropathy, you're going to find, when you very carefully test the other movements, flexion, lateral rotation, there's going to be some limitation of range as well. And of course, what you're going to have there is a hard capsular infill with the arthrokinematic test. UFA is going to look exactly the same, but without the extreme pain of arthritis or the hard capsular infill. Now, having said that, you can have an arthrotic joint that subluxes within the arthrosis. And in which case, when you do the PAM, you're going to have a hard capsular infill when you're doing it. Manipulate anyway, you're not going to do any damage, and it's possible that it will respond. You'll still have the arthrosis, but the subluxation within the arthrosis, you've cleared up. With sacroiliac joint pathology, the inner flexion quadrant is going to be positive, almost certainly. Fortin's, objective Fortin's is going to be positive. The primary SI stress test will be positive only if there is fair degree of arthritis present. If this is a dysfunction, they're not going to be positive. The biomechanical exam is going to be positive. And the hip, if it's tested carefully, isolating it from the SI joint, will give you full range. And no pain if you're doing it right, but pain if you're doing it wrong. But the range of motion will be full. Okay, and more. So what we've got is number of referrals. As I say, the pain is going to be much more achy. It's unlikely to come on when you move the spine, but it will come on after you stress the spine for some time. So this is often felt at the end of the day, sometimes first thing in the morning, it's achy sort of pain across there. So inner flexion quadrant is going to be negative, unless you really force this one up and really flex the lumbar spine when you're doing this, is going to be negative. What you can do here, though, is stabilize the innominate by holding ASIS down, and then you're going to have to use one leg, compress it, rotate it, and then lean on the thing and work it that way so that the pelvis doesn't move. The hip range of motion will be negative, full range and pain-free, provided again you safeguard the back from the forces you're applying. Objective fullness will be negative. To say this comes on after the pain comes on after exertion and activities, and the PAs over the lumbar spine will be positive. So as tendinopathy and bursitis, this depends on which one we're looking at, but a tendinosis, the inner flexion quadrant may well be negative when you do this. Deep palpation is really needed to get any sort of tenderness at all. Hip has full range of motion, and one contractile test hopefully will be positive. The problem with this is that contractile test may be in extreme extension, and that's what you see when you get a bursa as well that's not too inflamed. Tendonitis is much easier. Inner flexion quadrant is going to be very positive as you squeeze this thing. Deep palpation is going to be positive, 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 and it won't be have to be as deep as for the tendinosis rather. Mid-range contractures will be positive here and really quite painful and possibly weak, and stretching it is very, very positive. It's worth noting though, tendinitis is, and tendinosis, but particularly tendinitis, if that's right at the attachment to the lesser trochanter, then to palpate for this, you're coming from the back. You have to come in posteriorly, work your way onto the lesser trochanter, and then push towards the front of it. So it's really quite a difficult palpation. But unless you do that, you may not pick up these where it's attached to the bone. Bursitis is, if this is acutely inflamed, then the inner flexion quadrant is going to be positive. It's not so severely inflamed, then they may be negative. You need deep palpation again, and isometric flexions will be full range and negative, except when you're doing full extension and doing flexion. So your problem with diagnosis here is between the bursitis and the tendinosis. I'm not sure how you would do that if you've got a mild bursitis and a mild tendinosis or tendinosis. Visceral, if you're lucky, you'll get viscerogenic pain, which answers every single question you can have on this. Otherwise, you're looking at the behavior of the pain with the behavior of the patient. You're not looking at activity making this worse. In fact, when the pain comes on, these patients tend to be moving around as it does ease some of the pain for them. But the hip range of motion is going to be full range and painless. Sacroiliac joint tests are going to be negative, including objective foot-ins. Lumbar spine PAs are going to be negative. So this is a matter of an exclusion of the diagnosis if you don't have viscerogenic type pain. Inguinal hernia, inner flexion quadrant may be positive again, may not, but it may be. Hip range of motion will be full range and painless, provided you don't squeeze the hernia with your testing. It's less pain on lying than there is in standing, but that's the same with most conditions you come to. Exertion and coughing makes it worse, and there should be inguinal bulging. So here's the whole thing put together. I'm not going to leave this on. I'm not going to talk through it again, obviously, but it's there for you. If you want to pause the video, and look at this, feel free. As I say, I'll see about if I can remember to do it, and if I don't, somebody needs to remind me. I'll do a PDF of the slideshow that you can download. Okay, guys? Okay, I think the best thing you can do when you're looking at reasoning is to really think through what you're doing, not just do it by rote, which is what most people do. I'm hoping that by this point you're not doing that anymore. Really think about the processes that you're using, the information you're getting, the tests you're doing, how it relates to your hypothesis. Don't do random testing. Don't ask random questions. Focus your testing and your questions on the hypothesis under consideration. But I'm pretty sure you're going to be doing that at this point. Okay, I hope this helps. Take care, everybody. Bye-bye.